Good morning, and welcome to the session on consensus and controversies in spinal orthoses. Thank you for getting up early for the first early morning session. And I think we will have some other people coming in later, but we must stay on time, so we'll be proceeding at this time. In a minute, I'll introduce my co-presenters, but first I want to talk about why we're here. As a board member for ISPO, I received many requests for short courses on spinal orthotics. I was reluctant to initiate that effort because it's my opinion that it requires a full team of physician, surgeon, physical therapist, radiologist, orthotist to conduct those courses. And they were not always present in the countries requesting the courses. A couple of years ago, I addressed the the orthopedic annual meeting in Manila and spoke to a room of 26 fellowship-trained pediatric orthopedic surgeons. And I said to myself, well, wait a minute, maybe the full teams are here. It's time to go ahead with such a course. What is needed to put on that kind of a course? I went to the American Academy of Orthotists and Prosthetists, and I asked their spinal group, what is the resource you use in schools in the developed world for teaching spinal orthotics? And they said, there really isn't one. And I said, well then, what is the body of material that you think the orthotic students should have before attending that kind of a course? And I said, we don't really have that. And so we sat down together and we talked about and made an outline for what that material should be. And the consensus was there's a body of information that an orthotic student needs to have before learning the fabrication principles of spinal orthoses. Hence the need for a manual. I worked with my two co-editors, and we have developed the Atlas of Spinal Orthotics. There are 24 chapters by 31 contributors. It is online, free in the public domain. And if on your way out of the room, if you want to take your cell phone and aim it at the Q&R block on the poster, you will be able to download this textbook, 300 pages, for free. So this morning's session will deal with the content issues of this atlas. The basic science principles, natural history and pathologies of spinal deformity, fabrication principles, evidence-based use for orthoses, and the importance of team management. Today's presenters, I'm John Fisk. I'm a retired pediatric orthopedic surgeon and previous vice president of ISPO. I will be starting off. Following me will be Rafael Bundak, who is professor of orthopedic surgery at University of Manila in the Philippines. And clean up at the end will be Brian Malis, who is a certified orthotist in Chicago, Illinois, director of the Orthotics and Prosthetics program at Children's Hospital, and on the faculty of Northwestern University. So, to begin, I was asked with one of my recent visits to a project in Africa to consult on how to make an orthosis for this young man to treat his scoliosis. If you look at his photographs, you see A, he's young, B, he has a severe deformity, and C, this is probably congenital scoliosis because of the webbing that you see on his neck in the oblique view on the right there. Is he a candidate for orthotic management? There are things you cannot treat with a brace. You cannot treat the wrong diagnosis. You cannot treat the wrong age group. You cannot treat the wrong severity of deformity. You cannot treat deformities with severe thoracic lordosis. And there are social factors that may interfere with treatment. The family does not support the child. They cannot get in for the necessary follow-up visits. The child is a rebellious adolescent and unable to tolerate the bracing. Many social issues are involved. We have to remember that scoliosis is not one diagnosis. Scoliosis comes in many forms and fashions. In fact, there are probably more than 65 known etiologies of scoliosis. There's idiopathic, there's neuromuscular, there's congenital, and there's syndromic. These are the four basic categories that all of those 65 known etiologies can be fit in. Today, we are limiting our comments to adolescent idiopathic scoliosis. The others, most times, are not amenable to brace treatment. So I will talk about the natural history of adolescent idiopathic scoliosis. I'll touch on orthotic indications, the effectiveness of orthoses, the choices of different orthotic prescriptions, and the importance of the relationship between the orthotist and the physician. What is the risk of progression of a curve in a given child who presents with adolescent idiopathic scoliosis? We know a lot about this in terms of how populations behave. We know very little about how an individual will behave. It's largely related to growth potential, curve severity at the time of presentation, and then the pattern and the location of the curve in the spine. This is one patient, for example, a 12 plus 2-year-old female who on the left presents with a curve of 18 degrees, followed for 3 years without treatment, progresses to 50 degrees. Another patient, similarly, at age 11 and a half, presents with a 35-degree curve, followed without treatment for 4 years, and the curve has not progressed. What's the difference between these two patients? Well, let's explore that some. First of all, it was understood early that potential growth is related to curve progression. The curve on the graph on your right shows the dotted line of a typical growth pattern, very rapid in infancy, then a plateau in childhood, and a rapid growth peak in adolescence. Plotted against that dotted line is a solid line of over 100 patients with scoliosis. And you can see that on the average, there is curve progression at the time of the rapid growth spurt. In another study from Greece, looking at 85,000 children, 839 were found on school screening to have curves in excess of estimated 10 degrees. Of that group of patients, 18% were stable and did not change through follow-up, 15% progressed, 25% improved and got better, and that's very significant, and I'll come back to it, and 9.4% resolved completely. This was a mixed group of diagnoses and was not done with X-ray, and so it's a little hard to draw hard and fast conclusions from it, but it's an indication that there are 3 different behaviors: stability, progression, and improvement. And before making an orthotic prescription recommendation, you need to know where your patient is. In a study published in 1984, the principles of the relationship of curve progression and growth were documented. Here, we can see that curves that are on the lesser side, 0 to 20 degrees, if the child is young, risks are assigned 0 to 1, their potential for progression is 22 degrees. However, if the child is older, risks are 3 or 4 when they present, it's only about a 2-degree progression. But if you take larger curves, the risk of progression increases substantially. So there's a relationship between growth and the severity of the curve at the time of presentation. This is shown here graphically with on the abscissa is the severity of the curve. The risk of progression diminishes as age progresses, and on the lower graph it shows that the risk of progression increases with the severity of presentation of the curve. Growth can be predicted by looking at various parameters, and in a textbook there's a whole chapter on a list of many different growing potential parameters. The classic one is the Tanner classification of secondary sexual characteristics in children. And by that, we can determine the time of peak height velocity. Really, the only way you can determine that is by measuring the child on follow-up visits. But you can make predictions based on the Tanner classification. We know there's probably a genetic determinant involved there. It's of interest that adolescent idiopathic females on average grow to be taller, in spite of their curve, than those without a deformity. And of course, we know that males mature later than females, and you can make comment on that if you wish. So the risk of progression coincides with a peak height velocity. It, growing on average, ceases 3.5 years after that time. It occurs typically about 7 months before the onset of menstruation in females. So if you've got a post-menarchal adolescent, the risk of progression is substantially less. With curves greater than 30 degrees, there is at the time of the peak height velocity, there is a 70% risk of progression. With curves less than 30 degrees, there's only a 4% chance of progression. So if you were to treat that child with a low risk of progression, you could pat yourself on the back and say, what a great job I did with the bracing. But it wouldn't be anything you did, it would only be the natural history in that child. After risks are 4 to 5, there's only 11% chance of progression. And remember, boys' peak height velocity occurs much later than girls, on average about 1.5 years. So the natural history studies can tell us a lot about populations, which curves will progress, and it's essential in the decision making. But it's only an average of a group. It does not pertain to any single individual. Each patient is unique, and therefore each patient must be followed through their growing pattern. Recently, the Scoli score was developed. This is a prognostic test based on the DNA analysis of multiple loci, and you can develop a scoring between 0 and 200 that relates to the risk of progression. Less than 40 is low risk, 40 to 180 is intermediate risk, and over 180 is a high risk of progression. The Scoli score test costs $2,000 in the US and is not available to everyone. Can it predict brace effectiveness? We don't know that. And to date, there has been no prospective validation study to prove its true relationship. Here's a graph of the relationship between the SCOLI score and the risk of progression. As you can see in the orange, the risk rises significantly. The location of the curve in the spine tells something of the risk of progression. The lumbar curve and the double lumbar, thoracic and lumbar curve have a relatively low risk of progression. But again, these are based on population studies, not an individual. Things that have been reported in the past as prognostic factors, you can discount. Family history. Just because a mother has a bad curve doesn't mean the daughter is going to have a bad curve. The sagittal contour. Do they have a list to one side or the other? Not related to prognosis. The relationship of the rib prominence, the amount of rotation, decompensation, and lumbosacral anomalies all do not relate to the prognosis for curve progression. Let's switch now and talk a little bit about orthoses. The aim of orthotic management clearly is to improve the curve, to prevent progression, to prevent the need for surgery, and this is probably the most significant outcome, and to improve the appearance of the patient. The era of spinal management of scoliosis began in 1945. This is a classic old photograph of Walter Blount and his orthotist Al Schmidt as they are evaluating his child with a brace. Remember, the Milwaukee brace first was used as a post-operative immobilization device, and it wasn't until they found improvement in some of those post-operative patients that they thought they could use it as a preoperative treatment. The relationship with the ability of the Milwaukee brace to control curves was established early in a retrospective study by Lonstein and Winter, where the natural history of curves may be in the range of 68 or 80% progression, and the slide has jumped here on the projector, but the brace was able to control the curves in large groups of patients 40% of the time. In a large meta-analysis study of the efficacy of bracing, of non-operative treatment, on the left is the bar graph showing the risk of progression in untreated patients compared to the Charleston nighttime bending brace, compared to TLSOs, and clearly in the majority of studies in the literature shows that full-time treatment and ultimately the Milwaukee brace are the most effective means of treating idiopathic scoliosis. So we really have a lot of choices. We could use Milwaukee brace, the CTLSO. We could use TLSOs, and they come in many different designs, often based on, their names often based on the city in which they were developed. There's the Charleston night bending brace, which has been shown to be effective in certain curves. And there is the spine core system. And the spine core system, becoming popular now because it seems easy, they will admit in their literature that they have not proven progression in their patients before instituting brace treatment. So be suspect about their advocating that. What about chiropractic manipulation, electrical stimulation, and exercises and biofeedback? No effect. Don't waste your time. The considerations you have must be to what your orthosis is doing. What is the role of growth? How the brace works? The effectiveness of a given orthosis? And anticipate difficulties in managing the patient. So in this photograph of this Nepalese lady, you might think that these rings around her neck, which you could call a cervical orthosis, has lengthened her neck. If you take an x-ray of her, however, the normal at the bottom and her x-ray at the top, You see, the cervical spine has not been lengthened at all. It is rib deformity that was the result. You must understand the mechanism of what you are applying. So what is your brace doing? The need for a prospective, randomized, control study of the effectiveness of orthotic management of scoliosis was taken up by the University of Iowa in 2007. It was a multi-center study using a TLSO with monitors. The endpoint was how many patients were prevented from needing surgery. It was a $5 million grant supported by the National Institutes of Health, the Canadian Institutes of Health Research, and Shriners Hospital. Because it was prospective and randomized, many of the patients elected not to be treated, and they would not agree to randomization. And so they took that group as a separate cohort. So there was the preference cohort, the randomized cohort. Their endpoint was 50 degrees at maturity. The study was stopped early by the National Institutes of Health because bracing was demonstrated to be effective 72% of the time. It's interesting, the University of Iowa researchers didn't anticipate that it would be that good. I can't read this because it's too small up here, but I'll try. Bracing significantly decreased the progression of high-risk curves in the threshold for surgery in patients with adolescent idiopathic scoliosis. The benefits increased with longer use and brace wear. That was their concluding argument. So the braced treatment, and I recommend looking this one up, their best treatment success they found to be in moderate curves, actively growing adolescents, and it was dose related. So our recommendation, or the recommendation of many authors, is we observe curves less than 19 degrees. We require curve progression for between 20 and 25 degrees. In the 25 to 30 degree range, it's clinician's choice. Some treat, some required proven progression. Some don't treat and wait for surgery. In the 30 to 39 range, you treat immediately. You don't need proven progression. The odds of progression are great enough that you want to treat them. In the over 40 range, again, there's a dealer's choice. Some will require surgery, some will not, and it's the therapist's choice to do that. Over 45 degrees, brace treatment probably is not effective. There are contraindications to orthotic management. When growing is complete, no point in it. When the thoracic lordosis is severe, you can worsen that with your orthosis. Curves greater than 45 degrees are probably going to need surgery. Curves less than 25 degrees may have as much as a 15% chance of regression. And so you must prove progression before doing it. And of course, I mentioned earlier, social factors may interfere with brace treatment. There are many choices for braces. The Milwaukee brace is indicated for thoracic curves, double curves, and with an apex above T8. TLSOs can be used for single lumbar curves, single thoracolumbar curves, and an apex below T8. Wearing schedules vary by the clinician, but we advocate full-time use, 20 to 22 hours a day, with taking the child out of the brace for bathing and for recreational activities that are part of their normal school life. There is evidence for the effectiveness of part-time use and for nighttime only use, but this is only in specific curves, and they're well documented in the literature. The weaning process is simple. When the curve is complete, when the growing is complete, 18 months post-menarche, when the Risser sign is 4+, in males it must be 5, and during the weaning, you can use it part-time or nighttime only. That's the choice of the clinician. It's sort of like wearing a retainer on your teeth after you've had your braces off. The important treatment factors are the compliance of the child, the education of the family, family support, the enthusiasm of the physician and the staff, and the interaction between the physician and the orthotist. A couple of examples. The x-ray on the left shows the pre-brace treatment. The x-ray on the right shows 18 years after brace treatment. And again here, 20-degree curve progressed to 45 degrees, and the x-ray on the right is 20 years after brace treatment. So what do we know in 2017? Braces will work. We don't know how often. We don't know on whom. There has been no randomized controlled study, prospective randomized controlled study, yet there is evidence from the Scoli score and using a compliance meter to monitor growth. What is our future? We can anticipate that genetic testing will tell us more about predicting prognosis of the curves and the effectiveness of the brace. So pick your choice, but understand the evidence behind it. The Scoliosis Research Society has published guidelines for evaluating effectiveness of orthoses. If you want to study how your brace works, your population should include children over 10, small curves to begin with, Risser sign 0 to 2 in females, and premenarchal or within 1 year postmenarche. They must have, your studies must have standardized outcomes, a minimum of 2 years follow-up, with 5 degrees or less of progression, and you need to record the number that progressed more than 45 degrees. And of course, the percent taken to surgery. So which orthosis to use depends on the natural history, the curve pattern and location, philosophy and treating physician, ability of the orthotist, the results of brace studies, and the patient choice. Following me in this symposium will be Dr. Rafael Bundak, who's a professor of orthopedic surgery at the University of Manila in the Philippines, and Brian Malis, certified orthotist at the Children's Hospital in Chicago at Northwestern University faculty. Dr. Bundak, if you'll come up and talk on the role of orthoses in treating spinal infections.